Good morning. My topic is the fatal flashes, thermal and laser injuries to the eye. Well, according to statistics, 11.5 to 22% of ocular injuries are burns, which is more common in males. Mostly it is workplace, then domestic accidents and assault-related injuries. The incidence of laser burns are rising these days because of increasing commercial devices and consumer devices using lasers in them. And in about 20 to 75% of severe burns, the visual impairment is also severe. When you consider the difference in the mechanism of injury between thermal and laser burns, the thing that you have to understand is thermal injuries primarily affect the anterior segment due to the protective mechanisms, and damage is limited by the brief contact time. Whereas in laser injuries, these protective mechanisms are bypassed due to the focusing power of the eye, and the damage occurs much faster in high power lasers. Now there is a classification of these burns depending upon the degree of involvement, starting from epidermis to the deeper layers as first degree, second degree, third degree and fourth degree. There are different zones of the burns. The central zone of coagulation, where the damage is maximum and is usually irreversible, followed by the zone of stasis, which is potentially salvageable, and the zone of hyperemia, that is the peripheral area, which you can restore with even without an intervention. Why this zone and grade is important? That is to decide on the critical management as well as to have a good idea about the visual prognosis. Now the lasers, they have a classification according to the safety standards, that is an ANSI Z136 classification based on the wavelength, power, beam characteristics and the maximum permissible exposure. They are class 1, 2, 3 and 4. The thing that you have to note is most of our ophthalmology lasers come in class 3R or 4, which are the most hazardous ones, and hence the need of the use of protective eyewear of the specific optic density while you are using them. The exposure can cause retinal damage at powers of 5 milliwatt or more. The mechanism of laser injuries is just like how they are working on the retina by photocoagulation, photothermal mechanism, photochemical or free radical mediated injury, photo disruption by the high power acoustic shock waves. But the problem is the amplification due to focusing by cornea and lens amplifies the damage. The clinical features in thermal injuries are mainly restricted to the external, especially up to the bulbar conjunctiva and cornea, and posterior segment injuries are usually not very common. This include erythema, edema, blistering. Then on the lid, there can be tissue loss, which can later on lead to contracture, exposure keratopathy, then long-term scarring, ectropion, entropion, lag of thalamus, and also ocular surface disorders. Sometimes in the acute phase, there can be an orbital compartment syndrome, which needs an emergency management, including canthotomy, cantholysis, IOP control, and orbital decompression. In laser injuries, the injuries can be anywhere, like some iris holes, transillumination defects, anterior uveitis and cataract in the anterior segment. But more common is the posterior segment injuries like an RP destruction, macula hole, pre and intraretinal hemorrhage, vitreous hemorrhage, and later on a choroidal neovascular membrane. And the extent of the damage depends upon the power of the laser. There are two classifications, as Madam has already elaborated, the Roper Hall and Dua. Of these, the later Dua classification gives more importance to the clock hour involvement of the limbal ischemia and the bulbar conjunctiva, hence has got more prognostic value. The thing that you have to remember is this assessment should be done at the initial presentation itself, because that plays an important role in the medico-legal complications that may arise later. In the diagnostic approach, in the initial evaluation, you have to look for all the findings that I have already mentioned, giving specific importance to the history. What was the type, what was the duration, distance, the power of the laser used, and what are the protective measures, whether they were taken or not. The visual acuity has to be recorded, the baseline, as well as on the follow-ups that come on to monitor for the changes, which is of medico-legal importance. Slit lamp findings and all has already been mentioned. It is very important to note whether there has been an RAPD to suggest optic nerve involvement, and the grading should also be ideally recorded with the initial evaluation itself. The imaging modalities that is useful is OCT, FFA and not FFA, fluorescein angiography and UBM. OCT is mainly to look at the retinal layer disruption. If macular edema is there, to quantify it and to monitor the recovery, how is it happening. The fluorescein that documents the limbal ischemia and assess the vascular integrity. Later on, FFA is useful in CNVM. In UBM, you have to assess the anterior segment, the angle damage, ciliary body damage, etc. The management protocol mainly as we already have seen, depends on topical antibiotics, steroids, cycloplegics, and lubrication. That is in mild injury. When it comes to moderate injury, you have to step up. The same agents you have to use more frequently and give slightly more intensive therapy. And you can add oral vitamin C, doxycycline, autologous serum, etc. And when it comes to severe injury, along with that, you have to think of surgical interventions because mostly the damage will be more and they may lead to chronic problems which need surgical intervention. The interventions has been discussed again in detail in chemical injury include the amniotic membrane transplantation, tenoplasty and limbal stem cell transplantation. Of this, AMT is usually done ideally within the first week itself, which promotes re-epithelialization, reduces the inflammation and prevents scarring, whereas the limbal stem cell transplantation is usually done once the inflammation subsides. And in severe limbal ischemia, tenoplasty is helpful in preventing anterior segment necrosis as well as the corneoscleral ulceration. The complications can be permanent visual loss, which can occur in about 20 to 75%, especially in the higher grades in Dua and Roper-Hort classifications. Glaucoma can be seen in around 50% of patients, especially more in chemical injuries. Ocular surface complications include dry eye, limbal stem cell deficiency, and corneal melt. Structural complications has already been enumerated, and laser-specific complications are macula hole, CNVM. The prevention strategies adopted at the government level is mainly to insist on the safety standards, like what all are safe for medical instruments, what all are good for commercial laser equipments and all that. So the FDA guidelines regarding the labeling, specific hazard classification and documentation has to be strictly followed and checked before you use them. Especially the medical laser devices require specific clearances. There are specific guidelines by WHO as well as UN protocols to reduce workplace hazard by these equipments. At the institution level, you have to ensure that standard operation procedure is set for each equipment. The hazard evaluation has been done prior to the equipment installation. Regular audit and maintenance is very important. Having safety interlocks and emergency power off, and as well as the wavelength protective eyewear is very important. The access should be given only to authorized personnel, and periodic eye checkups of those who are doing lasers should also be done. Individual level, again, it is our responsibility to use the protective eyewear and the shields, and you should never be lazy in doing that. And you should be aware of the lasers that you are using. Thank you.